Thank you. Good afternoon and good evening, everyone. My mandate is to speak about radiation therapy in brain metastasis, and thank the organizers, Vijay and everyone else for giving me this opportunity. So I want to take one thing off the list at the beginning itself. There are a large number of patients of brain metastasis with poor general condition, and to basically treat these patients, we now have a guidance from a randomized trial, which is a phase 3 non-inferiority trial. It was called a QUADS trial, and the patients were randomized between optimal supportive care versus whole brain radiation therapy. And if you see the primary accrual criteria, it said that if there was uncertainty in the clinicians or patients' minds about the potential benefit of whole brain radiation therapy, and an MDT believes or concludes that the patient is unsuitable for either surgery or stereotactic radiosurgery, this was a criteria for accrual for the group for patients into the study. And it was primarily a study from United Kingdom. And what the study noted was there was no difference in overall survival, overall quality of life, as well as dexamethasone use. And these three key endpoints, not just overall survival, I think quality of life is also extremely important in these patients. And it showed that there was hardly any benefit even with treatment. And this was quite a revelation. But we all have to understand that the median overall survival in both the groups was between 8.5 to 9.2 weeks. That means close to 2.5 months. So in these set of patients where the life expectancy is close to 2.5, 3 months or less than 3 months, this study showed that whole brain RT can be safely omitted in patients. But how often do we see these? And of course, we see these patients quite often, but how do we know that these patients' life expectancy is low? And we now have guidance from diagnosis-specific GPA, and now we have some a molecular-specific GPA, wherein even molecular information is added, and you see that there are patients between GPA 1.5 to 2 and 2.5 to 3, where the median survival is between 10 to 13 months for 1.5 to 2, 2.5 to 3, 13 to 25 months. So these patients clearly are not candidates for omitting any particular treatment, whole brain radiation therapy. Even among GPA 0 to 1, 6 to 7 months, 5 to 7 months is the 7 months is for adenocarcinomas, 5 months is for squamous cell carcinomas. So there are a group of patients and they need to be selected. Of course, it is a little bit of subjective assessment. And there is a guidance through brainmetgpa.com, which I sometimes use. This is generated from a very interesting set of publication from Sperduto et al. I think some of you may be interested to go through this. But patients with better disease-specific GPA or better life expectancy, one of these treatments is available for all of them: surgery, radiosurgery, whole brain radiation, or targeted therapies, based on patient symptoms, steroid responsiveness, the location of meds. I think posterior fossa lesion was brought out by Dr. Turel. Number of meds, amount of edema, need for tissue diagnosis. Sometimes that is the only site of disease, the first site of disease. We need a tissue diagnosis. Surgery is the key. I mean, even if the patient has minimal symptoms. And other disease-related factors, how sensitivity is to radiation, patient factors, logistics, finances, etc., etc. But having said that, the biggest reason for neurocognitive decline is a brain met. And that we must never forget. We always believe the treatment is going to worsen the neurocognitive outcomes. Absolutely right. But probably the biggest reason why neurocognitive decline could happen is because of a brain met or because of a recurrent met. A single episode of seizure from a MET can reduce the quality of life significantly. The patient may go into an ICU, may have infections, may prolong hospitalization, so on and so forth. Untreated brain mets in eloquent areas may lead to permanent neurological deficits. So these all have to be kept in mind before we offer what kind of treatment and whether we offer treatment or not. So coming to whole brain radiation therapy toxicities, it is considered toxic. There are acute, early, delayed, as well as late effects. And these are some of the pathogenesis which I have mentioned. Most of the acute effects are reversible, that edema, headache, drowsiness, partially to an extent somnolence, which is early delayed, is also reversible. Some attention deficit and short-term memory loss is also partially reversible. What the intensity, the magnitude of the loss of cognition at 4 months is partially reversible at 12 months. But of course, some amount of demyelination and other effects on vasculature, gliosis, white matter changes are sometimes permanent, are irreversible, and even progressive. And that is the reason why whole brain radiation therapy is toxic in certain patients. But again, let's not blame the entire neurocognitive decline, burden of neurocognitive decline on whole brain radiotherapy alone. Patients who have brain metastasis may have baseline neurocognitive function, may already be at a loss or at a back foot because of the brain metastasis itself. The patient must be on anti-seizure medication. There could be systemic therapies, corticosteroids, intrinsic brain diseases. Maybe the patient may be older, may have Parkinson's or early onset Alzheimer's, and so on and so forth. Surgery probably also would contribute some to the neurocognitive decline. And of course, whole brain radiotherapy is also going to contribute in a big way as well. But irrespective of what I'm going to speak in the next few slides about SRS and all the newer advances, we do see patients such as these with so many brain metastases spread across the brain parenchyma, that except for whole brain radiation therapy, or probably even avoiding whole brain radiotherapy in a very sick patient, is the only option. But there are benefits of whole brain radiation therapy. It could be considered even reasonable in leptomeningeal disease, patients with innumerable metastases, multiple metastases, low RTOG DS GPA scores, medical contraindications. And it is simple to plan and deliver. It can be delivered at any center, literally treats local as well as distant intracranial sites. After we treat, there is no need for MRI surveillance. If you ask the dose, 30 grain, 10 fraction is probably the best. This is shown as per the RTOG kind of a systematic review of all RTOG studies. There was no benefit in increasing the doses higher than 30 grain, 20 fractions based on this Cochrane review. Patients obviously ideally shouldn't receive systemic therapy during the treatment, a week before, at least a week before and after it. So there is a break in systemic therapy while the patient is on whole brain radiation therapy. That also needs to be considered. And based on this, in some patients, at least, we do choose 20 gray in 5 fractions as an option when we do not want systemic therapy break to be quite longer. So patients with a reasonable life expectancy and performance status should not be excluded from receiving whole brain radiation when other options such as SRS and surgery and other treatment therapeutic options are not recommended. And benefits of whole brain radiation therapy, I believe, far outweigh the risks in properly selected patients. And as I mentioned, the biggest reason for neurocognitive decline is still a distant intracranial progression. Now coming to definitive SRS, initially studies from UPMC have shown that when patients were randomized between SRS plus whole brain radiation versus whole brain radiation, the studies were terminated prematurely because the local control was excellent in patients who received SRS plus whole brain radiation compared to whole brain radiation alone. There are a series of RTOG studies. This RTOG study of 333 patients, again, similar question, whole brain versus whole brain plus SRS, improved overall survival in solitary met, but you can see that there was trend towards benefit even with patients 1 to 3 metastases in lung cancers, younger patients, RPA class 1, and so on and so forth. And just to kind of understand the impact of this treatments, I would like to highlight this particular study, a 213 randomized study, NOA study. Obviously, patients were randomized to SRS versus SRS plus whole brain radiation. And the primary objective was determine if cognitive deterioration 3 months post SRS is less with SRS or with SRS with whole brain radiation. And you can see that the time to intracranial progression was much better. You can see that with SRS, 35% of them had progressed intracranially somewhere else, compared to only 11% who received whole brain radiation therapy, although the median's overall survival was not different. Of course, when I say no overall survival difference between addition of whole brain radiation to SRS is because obviously most of the intracranial disease which presented at a later date were salvaged successfully through re-SRS. So you can see here that nearly 50% of patients who received SRS, at least by 12 months, have an intracranial progression, and this must be told to the patient. So when we say we want to do only SRS, we must also inform to the patient that there is a 50% chance that the patient may still require a re-SRS, or a patient may develop another metastasis nearly a year after SRS alone. While SRS plus whole brain radiation therapy, although did not improve overall survival, had much better intracranial control over the disease. But having said that, it comes at a cost. A better intracranial control comes at a cost of a cognitive deterioration. You can see that SRS plus whole brain radiation, 91%, 97% at 3 and 5 months respectively, both were statistically significant compared to SRS alone. And if you see, and if you have to tell the patient what whole brain radiation therapy impacts over SRS, is you can see that physical well-being, functional well-being, there were FACT scores, which are simple to analyze, general and brain-specific, all significantly inferior in patients receiving SRS plus whole brain radiation. What happens to long-term survivors? Even long-term survivors alive 12 months after surgery, 15 SRS alone, 19 SRS plus whole brain RT. In the same study, you can see that even at 1 year, 94% of patients with SRS plus whole brain radiation had cognitive deterioration compared to only 60% with SRS. So there are now multiple studies which compare SRS versus SRS plus whole brain radiation for less than 5 metastases. All of them showed that there was no survival benefit with addition of whole brain radiation therapy, but there was cognitive decline when whole brain radiation therapy was added. So, and that is why in the West, not in our country, but in the West, clearly SRS has been the most preferred treatment option for most brain metastases compared to whole brain radiation therapy and only systemic therapy, surgery, and others. So as I mentioned, not associated with improved overall survival, associated with higher neurocognitive decline, both at 4 months and 1 year. But the assumptions are patients must be on MRI surveillance and get treated when brain mets appear, high rates of re-SRS after if whole brain RT is avoided, and potentially that could increase the lifetime costs for patients who may require re-SRS. There is also a small caveat that one may choose not to do re-SRS continuously if the brain metastasis velocity is too rapid. That is the cumulative number of new brain metastases that appear after the initial SRS is very rapid, then probably the next time you could consider a whole brain radiation therapy also. So there is also a controversy between size versus number. If we have multiple METs, do I consider 10 METs as multiple METs and say high volume METs? Or should I say even with 2 METs when we have large METs? So does it matter whether it is based on volume or number? And there are now some retrospective studies, and based on which systematic review showed that volume is more important than number, but unfortunately most studies still use, including the RTOG study, including the randomized study, have defined the metastasis numbers rather than by volume. So, but SRS for multiple METs, a lot of data comes from Japan, and you can see that patients were 1 to 4 mets were matched to, more than 4 mets. The overall survival did not matter even when you had SRS for multiple brain mets. There was no difference in neurological death, local control the same. So this study clearly showed that you could use SRS for multiple brain metastases. Another prospective study, again from Japan, showed that for a large number of patients, between 4 cc and 4 to 10 cc, and different number of meds, the median overall survival did not change by much when between 2 to 4 meds versus 5 to 10 meds. And 92% of patients actually died of systemic progression, not due to intracranial progression. And that said that probably SRS in multiple meds is also feasible. And there are now multiple ongoing trials from MD Anderson, from Canadian NCI, from other centers as well, to understand a number for basically the role of SRS for multiple brain metastases less than 20 in number. Now, we will also go through post-op SRS versus post-op whole brain radiation therapy. After surgery, as Dr. Prakash mentioned, most of them are not removed en bloc, so there is some amount of disease probably there, and is a local control better with the addition of SRS or whole brain radiation therapy. This trial did not show that you could do an SRS alone instead of whole brain radiation therapy. And another study, again a recent study, post-op SRS versus observation, also showed that the local recurrence was much higher in patients where post-op SRS was not done, only surgery was done. So SRS to surgical cavity is now considered standard after surgical resection. There is also a growing body of evidence for SRS before surgery. We call pre-op SRS. There are limited number of publications, but it seems promising because there are a number of potential advantages. The local control is better because the target delineation is better. The sterilization is better. The tumor is less hypoxic because of improved oxygenation. There is a data that when you do surgery, there is slightly higher risk of leptomeningeal disease post-op. That is also reduced in pre-op SRS. Reduced radiation necrosis because the dose required is slightly lesser. Majority of virided tissue is actually resected, removed, and there is improved systemic control. And these are the advantages, but potential disadvantages is lack of pathological confirmation, impaired wound healing. You need to do surgery within within few days, 48 hours of giving SRS. So that needs a little bit of coordination between the neurosurgical team as well as radiation oncology team. And there are multiple ways to mitigate pharmacological, non-pharmacological, and this have been mentioned in one of the commentaries which we have published a year ago, and we highlighted the role of memantine being one of the most cost-effective ways to prevent brain irradiation-induced cognitive toxicity, and we believe that it is underappreciated and underused intervention which can make a difference, and there is evidence for that. There is also a role for hippocampal avoidance. As you know that if you restrict the hippocampal region to 8 gray or less, there is a benefit in terms of lesser neurocognitive decline. This was initially showed in a phase 2 randomized trial, and then a phase 3 randomized trial was also performed, and both arms had memantine in it, whole brain radiation plus memantine versus hippocampal avoidance, whole brain RT plus memantine. 518 patients essentially showed that there is lesser neurocognitive decline in patients where hippocampal avoidance was performed, and this must be considered standard of care whenever whole brain radiation therapy is considered. But the chance of a person developing metastasis in the hippocampal avoidance region was 5% across several of these studies. So the unanswered question is, should we go for multiple brain metastasis, maybe 5, 10, 20 metastases? Should we consider SRS, as I showed from Japanese studies, spare normal brain, more neurocognition, you can spare higher intracranial failure, we'll need MRI surveillance, no need to interrupt systemic therapy because it's 1 to 3 fractions? Or should we go for hippocampal avoidance, much lower rate of intracranial failure, no need for MRI surveillance, lower neurocognitive failure, 2 weeks of treatment, so there would be some kind of systemic therapy interruption. And there is now a randomized trial just to answer this question, SRS versus hippocampal avoidance whole brain RT for multiple 5 to 15 brain metastasis. This is a study which is underway. Role of TKI, in the interest of time, I'm not going to talk about it, but it is an easy choice when whole brain RT is on the other option being considered. TKI, especially with very high response rates, 80 and above, with durable intracranial progression-free survivals, have shown that it is safe to for patients, some patients, selected patients definitely, who have targetable mutations, to offer these patients, instead of offering whole brain radiation, offering them TKIs and avoiding or deferring whole brain radiation therapy in these select group of patients. Response rates could be as high, depending on the generation of the TKI, 80 to 85% have been noted. Just to tell you, the radiation or an SRS has a response rates close to 90-95. So obviously for salvage radiosurgery could be used at any point of time. But having said that, there is, just to summarize because lack of time, approximately 50% of brain metastasis in patients whose primary tumors harbored no actionable mutations have been found to express at least one clinically actionable alteration. And when comparing tissue samples, there is some discrepancy between the primary as well as brain metastasis. There are distinct metastases sometimes. And when comparing tissue samples from non-visceral metastasis, from bones and and brain metastases, and it looks like that there are phylogenetically different origins of the dominant clones of primary tumor within these sites of disease. And hence, to conclude, in patients who have significant symptoms, in difficult locations, eloquent location, large size, lot of edema, need histopathology, surgery should be advised without any doubt. Mild to moderate symptoms relieved by steroids may need some intracranial treatment. If there are large edematous surgery, small SRS. If the patient is asymptomatic, has a targetable mutation present, feasible for TKI with high CNS penetration and response rates, then we go for TKI and defer the radiation therapy. Not feasible for responsive TKIs, SRS should be considered. Asymptomatic, no targetable mutation, chemo has shown some responses, but I think we should strongly consider at least SRS. 1 to 5 METs, SRS is preferable. FSRT, that is fractionated radiotherapy, could be considered in select patients and larger volume METs. And for more than 5 METs, either we have hippocampal avoidance whole brain radiation or SRS/fractionated SRS versus whole brain radiation therapy. And I think whenever whole brain radiation or a large portion of brain irradiation is considered, we must consider memantin. Thank you so much.
Thank you, Srinivas. Anyone has questions for Srinivas?
Good afternoon, sir. My question was, what complications are we expecting if this systemic therapy or chemotherapy is overlapped with WBRT? So, I mean, many times it happens within 3 days of, say, chemotherapy, the WBRT is scheduled and goes. So, what complications should we expect?
More rates of radiation necrosis have been noted in patients who have been treated with paclicarbo. There is data for paclicarbo. And even with pemetrexed cisplatin, there has been more. If the patient, at least a 1 week gap is not present between the chemotherapy. Some have said five half-lives of a chemotherapy agent should be allowed between chemotherapy and radiation. So I think at least a week's gap would avoid the higher propensity for radiation necrosis, which is noted even with 30 grain 10 fractions.
Thank
you. Can you tell us something more about memantin? So for how long? When do you start it? When do you stop?
So we start memantin within 1 to 3 days of starting whole brain radiation. I usually start a few days before whole brain radiation. We start with 5 milligram twice daily for the first week. Next week, I give 10 mg and 5 mg, and the subsequent week onwards, 10 mg twice daily for nearly 3 months. So that is the schedule which I usually use.
And what toxicities or drug interactions, and you can use it in all ages, so older patients as well?
So yes, so most of the patients which have been using memantine is for more than 18 years old. There is now a children's oncology group study which is evaluating memantine in low-grade gliomas as well, but we don't have the data yet for the pediatric population. So all adult population, I usually give it. The toxicities are typically mild, headache and dizziness. The good news is, despite patients being on multiple anti-seizure medications, the interactions are very, very low. So we really don't have to worry about interaction with anti-seizure medication, which are typically the inducers, enzyme inducers, and even chemotherapeutic drugs for breast cancer. It has been shown to reduce the fatigue and other symptoms related to chemotherapy as well. So I find it very useful for patients, so I usually give it. But the toxicities like headache and dizziness are the only complaints which occasionally are reported, but generally well tolerated.
Srinivas, very nice talk.
Thank you, sir.
This is one comment regarding what you suggested, that in Brainmets you do pick up 50% time or different driver mutations. Do you want to suggest that we increase the work for Prakash, that Brainmets we do biopsy more?
Yes, sir. Yes, sir. So this is just to I put it just to as a thought provoking, something to ponder upon. I agree that the recent Flora and the LAURA studies have shown actually quite a good correlation with patients who had EGFR mutation and had good responses and durable progression-free survivals. But somehow these studies keep cropping up. In fact, I've seen recently another study a few weeks back which said that the set of mutations in brain metastases versus peripheral tumors are different. So I don't know, sir. In fact, I will look to you to answer that question. I am not sure.
So I think so. Is the statement is right that your mutations are different because those clone becomes different, but those mutations which drives where we have therapy at this moment looks like with some data suggesting having a differences in mutations, they remain similar. But that's for basically for those driver which we have drugs. So for example, if I have a EGFR in a mutation in lung, in all probability I'll get EGFR in the brain primary also. But there will be certain other mutations which will be different, and because those clones which has gone to brain has evolved more. But I agree with you. We know that if we have intra-tumor differences in mutation, sure, a clone which has gone to brain and primary, there will be differences. Yeah.
Okay, sir.
Srinivas, I have a couple of questions. You mentioned that if it's eloquent, you would prefer to do SRS, or you would prefer it to refer to Dr. Shetty?
No, eloquent, in fact, if it is not very symptomatic and I mean not associated with a lot of edema, midline shift, I would like to offer SRS in that patient.
Okay. One thing is that I noticed in your slides that the cognitive decline kept on increasing as the time went by after whole brain RT. So that a difference between the arm of whole brain RT versus SRS for whole brain RT, the difference kept on decreasing when it was highest at 3 months, and it kept on decreasing at 6 months, which means that cognitive decline had a higher proportion of patient developed it at 6 months. And so my question is, at what is the time period after SRS when this cognitive decline would stabilize? So like I would say that at 1 year after this, no more patients, or it continues.
So very good question, because it gives me an opportunity to clarify another point again, or probably reiterate that point again, that after SRS, after 1 year after SRS, the primary reason for neurocognitive decline could be because of increased probability of distant intracranial progression. And that is why the difference between SRS and whole brain RT is slightly coming down at 1 year compared to the one at 3 months. Very good observation by you. So I agree with you that this is the truth, and that is why that's why I am a big fan of giving hippocampal avoidance whole brain RT versus SRS in multiple brain metastasis, because you treat SRS, but you do SRS, but there is always a threat that at 3 months or 6 months somewhere else we have missed, and we have to do absolutely high quality MRI not to miss the small lesions which could be potentially missed while doing SRS. So that is the reason I prefer hippocampal avoidance whole brain RT for multiple brain mets rather than SRS.
In one of your slides, you mentioned long-term survivors, and the long-term survivor definition used was 12 months.
Yes.
So somehow in medical oncology, we are not given that liberty to say that 12 months and above is long-term survivors. So do we say that with SRS also? The reason why I'm asking you is that don't we have like 5 years data or 10 years data with SRS, or 1 or 2 years? Because most of the slides, which even when I reviewed the literature and what you are doing, I would see 1 year survival, 2 year survivals. Don't we have that data in brain mets now that we talk about 4, 5 years or 3 years at least?
So I showed you the Sperduto et al. Papers both in JAMA Oncology as well as JCO in 2016 and 2018, on which they proposed their nomograms and brain met. Basically, it predicts the survival after a diagnosis of brain metastasis. And they showed that the best molecular group, GPA, had a median survival of 42 months. That is for adenocarcinomas. So 42 months is 3.5 years. So that is the best group. So obviously, I hope that, there are a number of, I've not covered immunotherapy trials which are there ongoing for for brain metastasis. I don't know whether they would contribute to prolongation of overall survival in the future.
Sorry, I have a couple of noted few questions. One of your slides, you talked about brain mets velocity, where you said that if the brain mets velocity was high, after SRS you would consider giving the patient, rather than doing a repeat SRS, you would consider giving whole brain RT. So is there some figure to that brain mets velocity you can put that this is that I would consider?
No, not yet. Not yet. A lot of them still do repeat SRS. But if it's obviously if after SRS, if 3 months I see 2 more mets, I would be tempted to give whole brain radiation rather than re-SRS, because I'll keep doing that again and again, and the patient will do that. So I will prefer whole brain RT. So there is I'm not aware of any specific number based on which we can take a decision.
Okay, and this is just a comment from you, and I would like to have the comment from Dr. Kumar sir also here. One of your slides, and which is correct, that most of the brain mets patients actually have systemic progression, and 92% of them actually have systematic progressions. Number of times we see that they may have driver mutation and there are multiple mets, and if they are asymptomatic today, these multiple mets we would just treat with CNS penetrating TKI and would defer the whole brain RT. Most of the time at our institute we would actually consider giving whole brain RT when the patients have progression post TKI. My thought while I was just pondering over your lecture, because there is also, we know that these CNS is like a sanctuary site. The drug penetration is less, so the clone gets the clone's exposure to the drug levels is different, and probably there are different kind of mutations can happen at the level of the clone in the brain mets. So could we have a strategy or think about a strategy where in multiple CNS mets, we start with TKI, 6 months, 7 months down the line, we do a re-imaging, and if there are small brain mets still left, we radiate them? Your thoughts and sir's thoughts on that?
I think I'll wait for Dr. Kumar's thoughts on that first.
So I think so. Tough one. So with the initial first generation TKI, we know some answers, and one of them answer was from our own study where we preferred giving RT, and we also realized at the time of progression they kept failing a good number in brain, and suggesting that if you're giving first generation TKI, it is good to have RT as a part of it somewhere or other. Maybe you give now or you give a consolidation RT, because somehow it doesn't do excellent job in a good job in brain. The problem is I think so that when you have a drug working very well in brain, now that becomes a challenge. Yes, it is a distinct possibility that tomorrow Srinivas can prove that when he is giving RT, I do agree that if you're taking those third generation TKIs, you get more progressive disease in the system. That's not true in first generation. So first generation is an issue where this concept is far appealing to me. And in fact, I see the data, I think so, some RT has to be given somewhere. The problem is the third generation TKI, what happens to them, where the disease progresses. And that becomes a challenge. Then do I give RT? Why not? We are thinking of giving RT for as a consolidation therapy, a trial called Syndas trial, which was presented last year ASCO. Only problem is that they took lot many exon 20 in the standard arm. So, and it was there was a PFS benefit, there was OS benefit in that study. So can we have that consolidate everywhere? That wherever you have something residual, ensure that RT is given. But the key will be, are we able to give RT where the cognitive dysfunction? Because if the moment these guys are people are living, like with alectinib, we have a 5-year survival of 65%. That is the same 5-year survival we have in ALL and pediatric ALL in India at this moment. So that someone can question, but we don't give alectinib to everybody. That also is true in India. I know. So that will be a question. Now, if Srinivas says cognitive dysfunction doesn't deteriorate, I'm sure many more people will be willing to accept it, because people are worried about the moment you get something in brain. That is the most helpless situation in the OPD. If you see a patient having disease in brain, you know whatever next is left there, that doesn't go in brain at all. So we change to chemotherapy, we change to targeted therapy, that is IV1, or immunotherapy doesn't go to brain. And after that, giving RT also has its own challenges when the patient is frankly symptomatic.
Any further questions for Srinivas? Yeah, there is. Yeah, Srinivas. Srinivas, your thoughts on that?
No, I agree with sir. I mean, everything what he said, and local consolidative therapy, and including intracranial brain mets also as part of that. The only thing is local consolidative. Some people are believers, some are not. But brain mets have to be radiated, as I agree with sir. Because I mean, one brain met, if it becomes symptomatic, he throws a seizure or he has an edema, there is so much of havoc in the patient's life. And I believe even with anti-seizure medications, we do occasionally see patients coming to us with seizures, or some patients coming with neurological deficits, and so on and so forth. So I mean, there has to be slightly lower threshold to treat those patients rather than not treat them. We have to, obviously, I don't want to treat every patient as much as possible, but I think more often than not, somewhere radiation therapy has to come in. And I think SRS is a big step forward. I think we have been using whole brain radiation therapy too much. It is not feasible in every setup, but SRS definitely leads to lesser amount of brain irradiation and definitely lesser chance of neurocognitive decline.
Yeah, questions, Ravi, you had a question?
Last question, sir. So, what is your take or what is your experience on what you prefer, sir? Whole brain RT with hippocampal sparing, or you will give whole brain RT with NMDA antagonist, or let's say we will give whole brain RT with hippocampal sparing plus NMDA antagonist? So, have you?
So wherever possible, I would try to give hippocampal avoidance whole brain radiation therapy with memantin. Memantin, we are using it for wherever, I mean, if you give a whole brain radiation, we would like to use memantin, not for SRS. So whether it is hippocampal avoidance or without hippocampal avoidance, sometimes it is not possible because the meds are very close to hippocampal region and you cannot do hippocampal avoidance. So you will have to give whole brain radiation therapy in those patients. So, but wherever possible, I would like to use hippocampal avoidance.
Okay. So,
especially in a patient who is likely to survive. If he's a strictly palliative patient whose life expectancy is very low, then obviously whole brain radiation therapy would be the easy choice.
Yeah. Thank you, Srinivas.